Dr. Kohlmeyer, who gets bladder cancer? Are there some people that are more at risk, and what are some of those risk factors?
Bladder cancer is much more common in men than it is in women, and probably the first through fifth risk factor is really smoking. The majority of patients who have diagnosis of bladder cancer do have a smoking history. But there are other exposures that could potentially lead to bladder cancer, exposure to particular dyes or chemicals in environmental or occupational exposure. Prior radiation therapy could potentially cause bladder cancer down the road. But smoking is really the #1 cause of bladder cancer.
And is that because some of the carcinogens get excreted in the urine and then they sit there in the bladder and in contact with the bladder for a while?
We think so. We're not 100% certain of the exact mechanisms, but most likely, the carcinogens in tobacco smoke do cause mutations and leads to the development of bladder cancer and other cancers, but bladder cancer.
Dr. Bajorn, I remember you told me, and generally there's a pretty long lag time for the development, and are there genetic susceptibilities here?
Yeah, there is a long lag time, and it can be in terms of decades between the initiation of smoking and developing bladder cancer. And this is a disease of older people. You can stop smoking, but the risk continues for decades afterwards. So one of the issues, for example, in lung cancer, if you stop smoking by 20 years later, your risk drops down dramatically. That's not the case with bladder cancer. And there are genetic differences that have been observed. There are these analyses of genetics in patients, and there are certain enzymes that detoxify hydrocarbons and aromatic amines that you see in carcinogens. And some of the genetic variations of these enzymes, these detoxification enzymes, have been associated with a greater or lesser risk of bladder cancer. So there's probably genetic variation superimposed upon carcinogenic exposure.
So Dr. Bachner, let's say, all right, we've got a patient who's come in, blood in the urine, they've been worked up, presumably then they end up in your office. What's the next step? Go in and do a biopsy, or what happens now?
Yeah, so the workup, as Dr. Bajorn had mentioned, is an X-ray to make sure that the kidneys and the tubes draining the kidneys are in good shape. But it also requires a cystoscopic evaluation, which is usually what a urologist will perform. That gives us direct visualization of the lower part of the urinary system. That includes the urethra, which is the tube that drains the urine out of the bladder, as well as the inside of the bladder itself. That typically allows us to make the diagnosis of a bladder tumor, and then that will require us at that point to do a procedure under some anesthesia where we will look into the bladder and scrape this growth away. That provides us the tissue sample so we can sort out exactly what it is. The key elements are the cell type, the grading. Again, this is how abnormal the cells look, and probably most importantly, what's happening to the wall of the bladder. Is it sitting on the lining, or has it begun to invade into the wall itself? These help us identify the different varieties of bladder cancer and therefore puts the patient on the right treatment regimen.
And you mentioned you go in and take a look and scrape. That's a cystoscopy? That's the terminology?
A cystoscopy usually is just the look inside, and that can be done with a flexible scope in the office setting. That usually is more diagnostic as far as just identifying a mass itself or a growth. The scraping is what we call a transurethral resection of this bladder growth, and that usually requires an anesthetic.
Mm-hmm. But it's usually done through the same sort of cystoscope?
Yes, that'll be done cystoscopically.